In medicine, we often celebrate the surgical scalpel, precise, decisive, curative. But sometimes the body isn't ready for battle. The heart is too fragile, the lungs too tired, the patient too sick. And in those moments, we don't charge forward. We pause. We adapt. We find another way. This is the story of one such way, a quiet, clever detour called percutaneous cholecystostomy. It doesn't remove the gallbladder, it doesn't cure gallstones, but it buys time. It relieves suffering, and sometimes that's enough. Hi, I'm Gaurav, and welcome to Gut Instincts, where we decode digestive dilemmas with clarity, curiosity, and just a dash of wit. Let's dive into the world of percutaneous cholecystostomy, or PC. Not that one, this one. Most gallbladder problems, especially those caused by gallstones, are treated with surgery. The gallbladder is removed in a procedure called cholecystectomy. Simple, effective, definitive. But what if the patient is too sick for surgery, too frail, too unstable, or just not ready? That's where a clever workaround comes in. Percutaneous cholecystostomy. It's not a cure, it's a stabilizer, a bridge, a lifeline. It's often called PCC in medical circles. But for today's discussion, let's just call it PC. Let's decode the term. Percutaneous means through the skin. Cholecystostomy means creating an opening in the gallbladder. So, PC is a procedure where a doctor gently pokes through the skin and guided by ultrasound or CT and inserts a thin tube into the inflamed gallbladder. This tube drains infected bile into a bag outside the body. Think of it like placing a tiny tap to release pressure, like deflating a balloon that's about to burst. The idea of draining the gallbladder isn't new. In the late 1800s, pioneers like Marion Sims and Cocker performed open gallbladder drainage surgeries. Fast forward to 1980s, with ultrasound and CT scans, doctors realized they could do it through the skin without major surgery. This minimally invasive technique began saving lives, especially among the elderly and critically ill. Today, it's mostly done by intervention radiologists and is a widely accepted procedure worldwide. PC isn't for everyone. It's reserved for patients who have severe gallbladder inflammation or cholecystitis but are too sick for surgery. And here are the 5 key scenarios. First, high risk patients with gallstone infection, elderly, diabetic, or those with heart lung issues. In these, the latest guidelines say if surgery can be done safely, go for it. If not, PC is your friend. Second, late presentations. When patients arrive days after gallbladder infection symptoms began the infection is raging, PC helps cool things down before surgery. Third, acute acalculous cholecystitis. There are no stones, just bad inflammation, often in bedridden or ICU patients. These are usually sick patients recovering from another major illness or surgery. PC can help resolve gallbladder inflammation in these patients. Fourth, pregnancy. Surgery during the first or last 3 months of pregnancy is sometimes risky. PC can buy time until delivery and help the acute inflammation resolve. Fifth, sepsis with unknown cause. When doctors suspect the gallbladder is the hidden villain in these sick patients with sepsis, PC can confirm and treat the cause fast. How is it done? Here is the nitty gritty. The skin is cleaned and numbed. A sedative keeps the patient comfortable and awake. Using ultrasound or CT, a radiologist inserts a needle, usually through the liver, to avoid leaks. A tiny wire guides a soft tube called a pigtail catheter into the gallbladder. Infected bile drains into a bag outside the body. Most patients feel relief within 1 to 3 days. The tube stays for 3 to 6 weeks until the infection settles completely. In skilled hands, PC is a very safe procedure with a technical success rate of 95 to 98%. But like any procedure, there are risks. There is a risk of bleeding in about 2 to 3% of patients, risk of bile leakage or tube blockage or tube displacement. So what happens after the tube is in? Once the tube is placed, the infection settles, the tract heals. A dye test, also called cholecystogram, may be done to check bile flow and the duct patency. If there are no stones and the infection is gone, a few patients may not need further treatment. But if gallstones are still present, cholecystectomy is the definitive cure once the patient is fit. Now, the main question: can gallstones be removed through the tube? In the 1980s, doctors tried shockwave lithotripsy (ESWL) to break stones. Chemical solvents were used to dissolve them, but these methods were slow, expensive, and had high recurrence rate. More than two-thirds of stones returned within 5 years. Today, laparoscopic gallbladder removal surgery remains the gold standard. New methods are being explored now that can do a similar job to that of a PC, like endoscopic ultrasound guided drainage to the stomach wall from within with no external tube. Promising, but still evolving. So, what's the bottom line? PC is a fascinating workaround, a modern twist on a centuries old idea. It relieves dangerous gallbladder infections quickly, safely, and without major surgery. It's not a cure for gallstones, but it's a vital first step when surgery is too risky. In medicine, not every victory is dramatic. Sometimes it's a quiet intervention, a temporary fix, a pause that heals. Percutaneous cholecystostomy reminds us that care isn't always about cutting. It's about timing, wisdom, and knowing when to wait. To know when to intervene is science. To know when not to, that's wisdom. Stay tuned to Gut Instincts to watch more such discussions about the health and diseases related to the gut. Thanks for watching. Bye.